Good afternoon, everyone. I welcome you all after the lunch session for the joint session with SCCT. We're going to be concentrating on plaque imaging. I'd like to call upon Dr. Mahesh Banno as the chairperson, along with Dr. Bhavin Jankaria for this session. So directly moving on to the first talk, which would be Coronary Artery Calcium Score, the current scope and limitations by Dr. Vinit Baliyan. Slide. Yes. So Dr. Vinit Baliyan doesn't require any introduction because he's already given a couple of talks. So I'm just going to hand it over to him.
Thank you. Good afternoon, everyone. I would again like to thank the organizing team for giving me the invitation. So I'll talk about calcium score, CT scope, and limitations. So the outline is like indications, then CT protocol and technical parameters, then reporting of calcium score CT, and how that information that we generate is used for clinical decision making, and then I will move to limitations. So why do we do calcium scoring? Coronary artery calcium scoring is basically we want to quantify the patient's risk. Traditionally, there is ASCVD or pooled cohort risk equation where you plug in patient's clinical background, their age, their blood pressure, cholesterol, smoking history, diabetes, all that information goes in and you generate a number. And that dictates next 10 years of risk of having atherosclerotic cardiovascular disease. But calcium score literature has shown that calcium score adds onto that. So that's why we do calcium score CT. So this is how that calculation looks like for risk assessment for atherosclerotic cardiovascular disease. You plug in these numbers, patient age, their sex, their ethnicity, blood pressure, total cholesterol, LDL, HDL, diabetes, smoker, hypertension, and it generates a number. And if where coronary calcium has been found to be useful is in the intermediate risk category. If someone has a risk of more than 20%, they're always going for statin and aspirin. And if someone has a risk of less than 5%, no one is going to put them at statin based on current guidelines. So in between 5% and 20%, there is a role of calcium score CT, and that's what we are going to talk about. So these are the current guidelines. There are not many, but some of them. There are a little bit differences, but they're mostly the same. So AHA, ACC cholesterol guidelines in 2019 say it, and we are talking about asymptomatic individuals here. Adults of 40 to 75 years of age with a 10-year atherosclerotic disease risk of between 7.5 and 20, they can have a calcium score CT to better stratify their risk, which can move them up to more than 20% guideline, like with statin, or it can downgrade their risk and they don't need a statin. In select patients, like if someone has a family history of early coronary artery disease, you can consider calcium scoring in select patients who are kind of between 5 and 7.5 10-year risk as well. SCCT is kind of similar, but they recommend for calcium CT for everyone between 5 and 20, and also recommend it in anyone who has less than 5% risk, but they have a strong family history. Canadian Society uses a different risk score, which is Framingham risk score, and they say anyone who has a risk between 10% and 20%, for whom treatment decisions are uncertain, they can have calcium score CT. The US Preventive Task Force last commented on this thing in 2018, and they said there is not enough evidence to support the use of coronary artery calcium beyond traditional risk factors. So how do we perform coronary artery calcium? Is initially the early use was with electron beam CT. They used it in single slice mode with ECG gated acquisition in diastole, 3 mm slice thickness, 100 millisecond acquisition time. They used a tube current of 130 kVp and reconstructed it with 500 by 12 by 512 matrix. Now it has been adapted to MDCT. The key differences are now we use 120 kV. Now tube current is variable, earlier it used to be fixed. And the other difference is slice thickness is now 2.5. And it generates some images like this. In the bottom corner, I don't know how, where the mouse, let's see here. Yeah, so you can see these are non-contrast CT images with ECG gating, and you can see the plaque very well. So how do we calculate? So Agatston scoring method is the most validated method, and it looks at two things: the density of the pixel that, in the plaque and its size, and it generates a composite score for each individual plaque, and that is kind of then added into a composite score for the patient. So there are 4 different categories, types of weighting. So calcium is defined as any pixel above 130 degree HU with an area of more than 1 millimeter squared, and above 130, as attenuation value of that particular pixel goes up, its weighting goes up. And then it is then multiplied with its size, and it gives individual plaque score, which is then combined to give the calcium score for the patient. So how do we report coronary artery calcium? So the most important thing is the absolute value, which is the best predictor of short-term to intermediate-term risk, of roughly up to 10 years. And it has a better, it's better for clinical risk assessment. We also generate age, sex, and ethnicity specific percentiles. They are better actually most for patient understanding, because by looking at percentiles they can get a better picture of how bad their disease is. And the age specific, ethnicity specific percentiles, they perform better if you want to calculate lifetime risk of coronary heart disease. And then we also report vessel specific scores. There is not much value to that, but I think some people want to know if there is a left main plaque or not. And because we are looking at calcium of coronary, we can also have opportunistic detection of calcification of the aortic valve, mitral valve. Coronary artery CT also gives an opportunity to look at the aorta, because ascending aorta and descending aorta are there on the image. And also, of course, we can look at the lungs. So these are the examples in incidental findings. On the image on the left, there is an ascending aortic aneurysm, and in the middle image, we can see there is a lot of calcification in the aortic valve, which can be associated with aortic valve stenosis. On the image to the right, we can see there is a nodule in the right lung. So these are the other things that we need to comment on calcium score CT. So coming to structured reporting for calcium score CT, which is called as CAC-DRS. It is kind of similar to CAD-RADS and kind of came into existence around the same time. And it can be actually, it's not only specific for coronary artery gated calcium score CT, but you can also apply it to non-gated chest CT. So the way it works is you generate a score of amount of calcific plaque. If you're using calcium score, then there are 4 categories. 0 is CAC-DRS 0, then 1 is 1 to 99, and then 100 to 299 is CAC-DRS 2, and then more than 300 is 3. And these categories define the risk of the patient. 0 is very low risk, mild, moderate, and moderate to severe. And based on these risk assessment, there are specific treatment guidelines with statin, no statin for CAC-DRS 0, and with both high intensity statin and aspirin for CAC-DRS 3. You can also use visual score, which is basically you just eyeball the images and just say if there's a little plaque or moderate amount of plaque or a lot of plaque, and you assign same score of 0, 1, 2, 3. And similarly, there are treatment guidelines. There are certain modifiers. So there is the number that we just saw, 1, 2, 3, 4 is the amount of plaque, and then there is another modifier that goes with it, which is number of vessels involved. So here, if someone has a calcium score of 0, then A0 means we are using a Gadsden scoring and their number is 0. But then you put another modifier right next to it, which is number of vessels involved. So A can be from 0 to 3 and N can be from 0 to 4. Similarly, for visual estimate, so we use the same modifier 0, 1, 2, 3, 4. With a V means visual assessment of plaque, which can be no plaque, mild, moderate, or severe plaque, and then number of vessels involved, meaning left main, LAD, RCA, and left circumflex. If there's plaque in 1, you say N is 1, and then so on. I mean, these are like very elaborate classifications, but in clinical practice, not many people are using them. Because still, the absolute number of calcium score still is the most valuable information that comes out of these scans. So here are some examples. I've taken them from the original publication for CAG-DRS. So in this patient, there is no calcium and no vessel involved, so it's a A0B0. And in this patient, there are 3 vessels involved, but calcium score is 45, so it's A1. Bivisually, it also looks mild, so A1 or V1/N3. Similarly, in this case, the Gadsden score is between 100 and 299. So if you give it a number of 2, visually also it looks kind of moderate amount of plaque, so you also can also give it a V2. And then there are 3 vessels involved, left anterior descending circ and RCA, so an N3. Similarly, you can get to up to N4 and V4 and A4. All right, so now we're going to see how the information from calcium score CT is being implemented in patient management. So again, we can see this is the 10-year ASCVD risk, less than 5, 5 to 7.5, 7.5 to 20, more than 20. And in first category, no statin is recommended. And there is no use of coronary artery calcium score CT in these individuals. Similarly, in individuals with a risk of more than 20%, they're always going to be on statin, so there is no recommendation of getting a calcium score CT. So value of calcium score CT is in between, where it can reclassify the patient's risk up or down. In these 2 categories, if there is calcium score of 0, statin is not recommended, and if calcium score is more than 0, then you can consider statin, but here statin is recommended. And again, these are mostly relevant for asymptomatic patients. These are some other ways how calcium score CT values have been used. So apart from ASCVD pooled heart equation, there are other ways to quantify risk for atherosclerotic cardiovascular disease. One of them is MESA risk score, which actually integrates coronary artery calcium into the risk assessment, and they say it is incremental. There are studies, this is a study where they validated that use of calcium score improves the predictive value of these risk scores. And this is another use, this is our publication in radiology, where we showed that we always use calcium score CT in all coronary CTAs, and this is the rationale. We looked at a lot of coronary CTs, and once we looked at coronary CT and and calcium score combined, and then we just looked at coronary CTA, and we saw a lot of small plaque can be kind of obscured by contrast, especially in low kV setting, 70 kV to 90. And here we can see there are a few specks. This is a MIPT image, so we are trying to show it really well, but it was much more subtle. But you hardly can appreciate these plaque in the CTA. So that is another use. Basically, that's how we use calcium score CT until very recently. We hardly did any calcium score standalone CTs before the 2018 IACI guidelines came out. So yeah, so calcium score CT can be a useful adjunct for coronary CTAs. And these are more recent papers where people have looked at how the calcium score CT information is being used in the clinic and how it is impacting patient management. And this is a systemic review, and meta-analysis suggests that non-zero calcium score has been associated with higher likelihood for pharmacological and lifestyle interventions. Although it is important to know that these calcium score based recommendations where you kind of upgrade or downgrade someone's risk is based on historical data where we say if someone is 7 to 25, 7 to 20% risk, and if they have a calcium score, they kind of have similar risk profile to as 20%. But it is yet, because we have been using them only recently, it is yet to be seen if these pharmacological interventions have actually resulted in any mortality or survival benefit. So coming to the limitations of coronary CT, coronary calcium CT, and there is only mostly one, which is it cannot detect non-calcified plaque, and as we have recently heard and we know that atherosclerosis plaque begins as a non-calcified plaque, and calcifications happen in late stages of the disease. So especially in young individuals, you're going to have a lot of false negatives, and it can negatively impact. If you're downgrading someone based on if they were 7 to 20% risk, and based on calcium score, you are downgrading them and you're saying they don't need a statin anymore, we don't know if that is going to have a detrimental impact on them. So these are more recent publications. Initially, there was a lot of calcium score of 0 had a lot of popularity, that once you have a 0 calcium score, you can't get much coronary artery disease, but it has been there has been contradictory evidence recently, especially in young individuals. This is a study published in British Journal of Cardiology where they showed that patients, especially younger than 40, a lot of patients have a high non-calcified plaque burden in younger than with a calcium score of 0. And another more kind of popular study is a Danish study where they showed that the value of calcium score of 0 changes with patients' age in symptomatic patients. If you are looking at younger than 60 years of age and they are symptomatic, there is very high prevalence of obstructive non-calcified plaque in these population, and they are associated with adverse outcomes. So calcium score of 0, I think, is a mixed bag, and you don't know what you're getting. We should interpret that with caution. Another limitation is calcium score CT. There are some technique-related limitations because we are quantifying plaque based on 2.5 millimeter thick slices, and you can see in this, RCA has these bright pixels, but they're kind of averaged out with fat on thicker slices, and they were not detectable by the score calculator. So you can miss some plaque just by, even calcified plaque, by the existing technique. But we still continue to use thicker slices because that's how it was standardized. So coming to conclusion, calcium score CT is a useful adjunct to traditional atherosclerotic disease risk factors and guiding management in intermediate risk population. And it can also be useful adjunct to coronary CTA to kind of enhance the sensitivity to small plaques. But failure to detect non-calcified plaque is the probably only but a major limitation. And we have seen that calcium score, having a positive calcium score is associated with more pharmacological and lifestyle therapies, but I mean, we need more studies to see how these modifications are impacting patient survival and mortality.
Thanks, Vinit.
Thank you.
Thank you. Do we have any quick questions from the audience? So just a quick comment. I think the biggest challenge still remains the lack of mortality and long-term benefit, because I guess at the end of the day, if a person is not going to take lipid-lowering agents, no amount of calcium score study is going to convince them. And so the only real role is a person willing to take, but not fitting into a high-risk, a 20% ASCVD criterion. So more and more, at least in practice, we are seeing that the role of calcium score is very, very limited to a very small section. But I think what we're seeing is that when we're doing what we call opportunistic mentioning in patients who come for a CT chest, for
Yes.
example, who've never had a checkup done for risk
Yeah,
stratification.
yeah, yeah.
You can push them into at least getting
Yeah.
risk assessment done.
Yeah,
So I
yeah.
think there probably there is a role, but I'm not sure
Yeah,
where
I
else.
think that kind of also goes both ways because there are no well-established guidelines. Some people just recommend coronary CT looking at that, but the way we handle it is if there is calcium, we mention it in the report, but we leave it to the physician. If they are symptomatic, they need testing. If they're not, then they should just do a risk assessment and see if they need statin.
So, yeah.
Are there any studies to show what is the percentage of non-calcified plaques that can be used on a calcium?
Yeah, there are many studies, and it's variable because if you take younger population, like less than 40, everything will be missed. And if you go to older ages, because most of the plaque calcify by that time, so I don't think we can use a particular number. But yeah, we know that you miss much more in younger patients than elderly.
But if you were to go through any of the articles based on the PROMISE and the Scott Hart studies, you will find at least one article that talks about in what percentage of coronary angiograms they found non-calcified plaques while the corresponding calcium score was 0.
Yeah.
So you'll get the data, it varies as Vinit said, but both the Scott Hart and PROMISE have articles based on this, so you can just check.
The purpose of the calcium score doesn't arrive before the age of 40. So you have to have calcified plaques. There are not be non-calcified plaques because the whole aim is, it calcifies over time. The thing changes when the patient is on statins. So patients who are on statins where the calcification is much faster. So there you will find that the calcium score starts rising very quickly because the whole intent of the statin is to cementify the plaque. Right? So it's very important to understand that before the age of 40 to do a calcium score, you will very surely get an under 100 or maybe a 0 number. But that definitely does not exclude the possibility of a calcium, of the patient having atherosclerosis. Okay, so you need a CT angio for atherosclerosis for sure at younger patients. And I also want to just, yeah, go on. I want to announce that this happens to be an SCCT IACI joint session. And the SCCT wants to actually just sort of, inform you all and cross-collaborate. This is the first time that IACI and SCCT are having this joint session, and we do hope that in future there'll be more and more people taking on membership of SCCT. We do offer discounted meeting registration. There's access to hundreds of online education courses, recordings, and websites for anybody who becomes a member. It's free and discounted online CME opportunities, online subscription to the JCCT, monthly membership, and there's lots of path-breaking news on cardiovascular CT because both organizations are really looking at cardiovascular CT. And then we've got professional development, access to member libraries, discounts on verifications, board exam preps, and leadership opportunities and voting. So just to let you know that SCCT is holding this joint session, and we do hope that there'll be more membership from you all. Go on, question.
See, the calcification is just a tip of iceberg. So when you have a calcification, there is underlying atherosclerotic plaque. That is positive.
Thanks, Vinit. Can we do it at tea time, please? All late. While Ashita is introducing, the problem with calcium score is there's a never-ending series of questions. So maybe what we can do is, if we can keep all the questions at the end when we finish, if the speakers are all here, we'll take we'll do a 15-minute Q&A all over again. So we can do that.
Yeah, that's a great idea. And also to remind you that you can ask questions on the app, the IACI app. So please feel free to type in questions which haven't been answered during the sessions because in the interest of time. And we'll be able to answer after looking at them. So the next speaker